So I wanted to really focus this talk on one big question, and that's the question, can we actually still hope to eliminate malaria in Asia now that artemisinin resistance has emerged in the region? And it's worth just looking at that from different aspects and seeing what we can do to give it the best chance it has. Just looking at what's happened before, the impact of drug resistance, previous rounds of drug resistance, which John mentioned in his talk. If you look at, for instance, with the global malaria eradication campaign in the 50s and 60s, one of the key weaknesses that was often cited in that campaign was the reliance on a very small number of tools. And in fact, the resistance developing to DDT put the brakes on people's confidence to eradicate. DDT was used so widely during the earlier eradication campaign, and it certainly caused a huge amount of discouragement when people started to find resistance. Today, this talk is obviously focusing on artemisinin resistance, but certainly within Africa at the moment, the concerns on the resistance to the pyrethroid insecticides, which are used on treated mosquito nets, is another major worry in that region, something we have to look out for in this region, although so far there isn't the same sort of level of concern, and it doesn't seem that there's much sign yet of resistance in the major vectors. And then if you look at the major loss of chloroquine, which came first in Southeast Asia and Latin America, and then later on in Africa, there was very much, as a couple of people during the symposium have already mentioned, there really is evidence that there was increasing numbers of cases and deaths in children as chloroquine resistance increased in that area. So if we look at where we're at the moment in terms of progress within malaria control and elimination, just going back a few years to 2009, and at that time it seemed that malaria had reached a very high point in malaria control. The levels of optimism were extremely high. There were so many presentations where people were showing enormous impact from the increased interventions. We had excellent tools that we could use both to treat and to prevent malaria. Political will was extremely strong and funding was increasing. And yet there were still major obstacles in actually delivering these interventions in some areas, and particularly trying to reach the remotest populations. The funding was always fragile, and there were also, even a few years ago, the first signs that some of these tools may not last, and we really are depending on a small number. Now, it's quite encouraging to see that 4 years later, in 2013, that political will and support are not waning. I actually thought they were starting to, but the signs are that things are going, that it's holding steady at the moment. And the calls for elimination are becoming louder, which is great. The overall funding, I think it steadied off a little bit after 2009 as a total, but certainly the most recent pledges, I think, for the Global Fund have been very encouraging, and so we still have an opportunity to do a lot while we can. So I think that sets a very good scene, but also in this region, in those years, the efforts to contain resistance have been accelerating, and the decline in falciparum incidence in all the countries of this region, there have been very dramatic declines in incidence. But at the same time, despite all this, resistance is increasing. Now, I know people come from different backgrounds, so I'm just going to say a very brief description of about the history of antimalarial drug resistance. It'll be a bit boring to some people in the audience, but judging by the posters, people come from working on a number of different diseases, so I thought it was worth it. obviously, it's very clear that it's a major bottleneck in controlling malaria. And the first reports of chloroquine resistance came out in the 1950s, chloroquine having been a very, very valuable, relatively simple, relatively cheap drug that had been used for some years, between 10 and 20 years at that point. And then Asia has had to fight resistance to every drug that's been used. As soon as a drug comes into use in this region, resistance eventually develops. And it's always been found first in the same area on the border of Thailand and Cambodia. And this led to moving to increasingly more difficult treatments, more costly, more complex. The 1980s was a time when the only treatment that really worked for falciparum malaria for an adult was 84 tablets. And since one of those drugs was quinine, which gives terrible side effects after 2 or 3 days, it's very unlikely that anyone ever actually finished a treatment. And yet now there is a spectre that we might actually be going back to that very same combination, or at least a relative of it, with quinine and doxycycline, as those drugs actually do still work. So then Africa followed Asia, and that's obviously one of the things that's driving a lot of our greatest concern for what happens here being transferred to an area where the burden of malaria is so much higher. But luckily at that time we did find rescue in the form of artemisinin combination therapies, and that has been part of a major upsurge in improvements in malaria control. Just for those who are less familiar with this area, this is just briefly to show that foci of artemisinin resistance have now been reported in 4 countries in the Greater Mekong sub-region. And they're, as you see, scattered predominantly around the borders of these countries. So this is just to show the areas which have been classified as Tier 1. These are areas with credible evidence of resistance, the dark brown areas. And this was the situation up to, which was reported up till last year. Earlier this year, some of this has been updated, and you can see there are there's an extension of the areas that are classified as Tier 1. The 2 areas that have now entered Tier 1, one is in northern Cambodia, and there's also an extension in the area of Myanmar on the Thai border. So then the question is, how do you get rid of resistance? The overall strategy, as people have been saying earlier this morning and today, is eliminating falciparum malaria. Now, some people have talked about broader elimination of malaria, but clearly for resistance, the primary element is the elimination of falciparum. Another aspect which is often talked about is removing selection pressure for development of resistance. However, the only thing you can really do in order to remove that selection pressure is not to treat patients, or at least not to treat them with the drugs where resistance has developed. And this has become an area of some controversy, particularly now, where we actually don't really have many safe and affordable drugs to choose from. I think some of you are already familiar with WHO's strategy for planning to contain resistance. They have a global strategy that was developed a couple of years ago. And a lot of the ideas within this strategy came from what was being done in this region, where people had been faced with the issue. And so the focus is on these 4 pillars: stopping the spread of the resistant parasites, increasing monitoring and surveillance, and trying to evaluate the threat, improving access to diagnosis and rational treatment with the right drugs, and then investing in research. And that's underpinned by the importance of motivating action, advocacy, resource mobilization. So some of the key areas of focus in trying to contain or eliminate artemisinin resistance are these. Working with mobile and migrant populations. These are the populations which are often considered the most likely to harbour parasites, to carry them from one place to another, but they're also the people who are often most difficult, who have the most difficulty themselves in accessing prevention and treatment. Another big area that I think was just mentioned in the last question was the issue of surveillance. Until we actually know where these resistant parasites are, where the people are, etc., then it's going to be extremely difficult to target our efforts to them. Suppressing monotherapies is another key pillar of the strategies. The idea, as many of you know, is to make sure that you can protect artemisinin by having it combined with a drug that works in a different way. And at the same time, the artemisinin, as a very effective drug up till now, will protect its partner drug. So the use of monotherapies is really going to undermine that. And this means working more closely with the private sector, understanding patient behavior, finding ways of encouraging better use of drugs. Joint action by countries in the region, it's very difficult to consider looking at resistance containment in a single country without looking across the region. And then a newer challenge to address that's come up quite a lot over the last few months, really, which perhaps had not had much attention as part of the strategy a couple of years ago, was that since we are trying to eliminate falciparum malaria in order to respond to resistance, then you really do have to think more about the problem of asymptomatic and low density of parasite carriers and how to address these. And that's something I think that's taken a lot of people by surprise as an area that they hadn't really covered in their thinking on strategies until recently. So what is being done? There's obviously a call for more action. There's WHO has launched an emergency response plan. This is a very good framework for action with a very useful set of recommendations. It's not, though, an action plan that gives all the details about the priority interventions for implementation, and countries need to know exactly what it is they need to do. There's the new initiatives which were referred to earlier. So this is just showing some of the efforts that have been made. I mean, the first areas that really were identified as having a problem and have been mounting a response are Thailand and Cambodia, and particularly around the borders between them, and that they've been undertaking artemisinin resistance containment efforts now since 2009, and they've got additional support now from the Global Fund. And then more recently, Myanmar and Vietnam have joined in with, as resistance was discovered there too. So as you see, it's all quite recent. So everybody's really learning what to do. The information base for figuring out if anything's working is very fresh and rather small at the moment. The joint assessment did conclude that, as far as they could see after the first 2 or 3 years, that a good start had been made in trying to address artemisinin resistance. And there was already some impressive impact as measured by reductions in incidence of malaria in the affected regions, but also looking at the coverage of the interventions and the intensity of the services. It seemed that there was, at that time, that what was set out in the global plan was an appropriate response, although some adaptation may be necessary. I think people are starting to continue to think, are we using the right strategies? And it's this thing that John was mentioning about, do we just need to do more and better, or do we need to be looking at new tools? I mean, in some ways, whether it's useful to actually debate those as two separate issues. I mean, to me, it seems that you have no choice but to do both if you can, and if you could afford it. So it does seem, though, that there's still not enough really being done. with the sort of levels of quality and intensity that we actually need, because we really don't have very much time in which to make this happen. Funding is always limited. There has been, obviously, as you saw in the earlier slide, there's been quite a lot of investment in artemisinin resistance efforts, but there's still gaps, there's still uncertainties in the funding as well. So, so we really have had quite a lot going on, but there are some major new issues coming up. DHA piperacin, which is one of the drugs that's relatively new and everyone thought would have a long and healthy future, is starting to show signs of failing in parts of Cambodia, and quite rapid deterioration as well, even in areas that have very low transmission, which people find quite difficult to understand how it could happen quite so rapidly. There's also warning signs of treatment failure even to atovaquone proguanil, which is a drug that's been had very limited deployment in the region. There's concerns that there could be, then this is just a risk, but there could be cross-resistance between two of the partner drugs that are being considered, piperacin and pyronaridine. And basically, there aren't any promising drugs in the very short-term pipeline. The one exciting thing, which I think people will be hearing more about at this meeting and in other sessions, is that there has been a search, a very intense search for a molecular marker that would actually show us directly which parasites are resistant, and they seem to have found one at last. And so that's really going to help us. It's going to mean that we're much less working in the dark than we have been up until now. We can actually track where if artemisinin resistance is spreading and how quickly that's happening. So there's quite a number of implications of this situation, and we can't be complacently relying on current tools forever. Have to keep that pipeline fuller than it is at the moment. And we also are going to lose good tools more quickly if we don't take system strengthening and regulation seriously. Although it was quite interesting, I think in one of John's slides he was showing some of the elements which he described as the reasons why elimination may be possible in Asia, the special features of Asia that would enable elimination, and there was a couple related to strong health systems, economic development, increasing peace, and yet despite the fact that the region is enjoying in many ways all three of those, it's just at this time that we start to see this increase in resistance. So it's quite interesting that those factors don't seem to be the ones that are driving resistance, which is very interesting. One thing that a lot of people worry about is whether we're missing the main target. We don't know enough about the routes of spread of resistance. When the resistance response activities started in 2009, they were designed before that in 2008 mainly. The big question was how widely do we start the containment activities, and in the end, I think the decisions were made partly on just how much people could afford to do and how much they dared to spend, rather than necessarily having enough of a sort of boundary of work beyond the area where resistance had been confirmed. Also, I think there's the issue of how to support catch-up towards elimination in Myanmar. It's the malaria incidence has been considerably higher than other countries in the Greater Mekong sub-region, and it really is important to catch up with the other countries so that there isn't a major pool of potentially resistant parasites to reinvade. So it's often useful to ask ourselves now whether we set our sights too low in the first years of the response. But I thought it might be interesting to consider some of the things that could happen if we abandon the artemisinin resistance response. People have sometimes thought maybe this is just too much effort in an area where actually malaria is much less of a burden than in Africa. So people question sometimes, why do we invest so much funding here when actually we could be getting much more benefit from investing more where there's more malaria? Or the countries themselves would sometimes understandably feel that they should be investing their own resources in control of other diseases which are of more immediate concern to them. So some of the things that would happen is obviously we'd have to return to non-artemisinin combination therapies, and we don't really have a lot of choice as to what those would be. As I mentioned, atovaquone proguanil, hugely costly. It wouldn't be a good drug to lose because it's an extremely effective prophylaxis drug. At the moment, if it is used, it's used with directly observed therapy, and that adds to the price. And there are concerns that if you used it on its own, that would be lost very quickly also. And the other one is going back to our old friend 7-days of quinine together with doxycycline. So we would find costs to the patients would be rising again as patients suffered multiple attacks of malaria, and the economic burden would go up. This could affect tourism, and also the hopes of actually eliminating malaria in the area would be lost as well, and we could start to see investment falling off. And also there's the issue of the threat of spread to Africa. On the other hand, if we do invest in artemisinin resistance containment, there's not really much to lose from doing this, apart from the fact that it's rather expensive. But the bill is actually not that dramatic, and it's a case of building on the programs to strengthen control. Hopefully, it would mean that we would actually achieve malaria elimination faster. And during the time when affordable control tools remain effective, if elimination is drawn out over an extremely long period, it means that we'd have to go through quite a few rounds of different tools as we lose one by one. And then, obviously, extending the useful life of the drugs that we have increases the return on the development costs of those drugs, which are extremely high, and means that we preserve the investments we've already made. There are lots of synergies between containment and elimination. Containment efforts have led to an intensification of malaria control. They've led to strengthening systems, especially, I would say, the surveillance systems and also some of the supply systems. They've increased the focus on quality, and they've field-tested a lot of very innovative systems. So the way forward is really that there's nothing more to do than to accelerate elimination before drugs fail further. And accelerating elimination involves a whole menu of different specific elimination strategies. I'm not going to go through all of these, but there are very well set out strategies for elimination, and these really offer a lot of prospect of making a rational program. So just looking at trying to connect the resistance response to the malaria elimination and how one can enhance the other. Both the goals both need extraordinary efforts to control malaria, even in areas where it's less common. So they both have to deal with the unclear link between resource allocation and disease burden, which makes national priority setting quite challenging. In fact, in Cambodia, I think one of the reasons that the resistance response was supported quite strongly was because it came at a time when national leadership was calling for general malaria elimination, and that was very much a trigger for supporting particular resistance containment activities. So there's a lot of beneficial side effects of doing resistance work for elimination. The surveillance improvements that have been tested, and you'll be hearing more about those after coffee, so I'm not going to go into them in any detail in this talk. Working more clearly and effectively with the private sector, learning to work with mobile populations. I think people are still learning a lot, and it's an area that still has created a lot of challenges and some answers, but there's still a long way to go in that area. Both of them need a real obsession with timely, local, and accurate information, and also use of that information, much more than has been normal in recent years. And obviously, it's important that this obsession with information doesn't actually slow down the response by inhibiting action until you've got the information, but a sensible balance is needed there. And obviously, they do both need to link the surveillance with timely, effective responses. Just a couple of examples of Malaria Consortium's role in the resistance, response, and elimination. The areas where we're focusing are on the surveillance, monitoring and evaluation, and implementation research, as well as quite a bit of work on behaviour change communication and on advocacy. In the research, we're focusing really on research to improve delivery of existing and potential interventions, as well as testing new systems and innovative tools and strategies. And then just trying to get a better information base for moving forward. We've developed a big interest in much broader and deeper epidemiological monitoring as a basis for dealing with artemisinin resistance. And that's partly because we do need to move towards much more targeted programs, need better local data to do that. We also realized just how little we know about and understand about low-level malaria transmission in Southeast Asia. A lot of assumptions are really being questioned these days. Also, for testing interventions, it's actually getting more and more difficult to actually set up big trials because of the low levels of disease to actually measure the impact. So the way we're looking at it at the moment in a number of cases is rather to undertake long-term, small area, very intensive monitoring, trying to get a real picture of what's going on by collecting information on all the potential causative elements, and then just trying to interpret what's going on in relation to the interventions being used. I'm just going to give one small example of some early results from this type of work that we've been doing in Pailin area in Western Cambodia, which is the area where much of the first reports of resistance have come from. It's a small example, but I think it raises a few interesting and challenging points. This was a small household survey in this area. The idea is that these household surveys aren't large, but they'll be repeated on a regular basis. And one of the things that it really illustrates is just how low the malaria prevalence is in the area that we're working. This is prevalence as measured by microscopy. Obviously, different tools give different prevalences, but it was only 0.2%. And that was all Vivax, which is not so worrying for resistance. The coverage of interventions was impressively high. It seems that in that part of Cambodia, the national program has really achieved what it was aiming for, which was real universal coverage. So 97% of all households had at least one net, long-lasting net or a treated net. 90% of them owned at least two nets. And the average number of nets in each house was 4.2. So that meant that for households with at least one net for every sleeping place, that was 86% of the houses. And so they've reached a proportion of households with at least one net for every two people, which is the target of 82%. And the worrying thing was that when they were finding out who'd been sleeping under the nets the night before, that was only 53%. That was just looking the one night before, but there clearly are issues of trying to do something to improve actual use of the nets. They did get more information on reasons for not using the nets the night before, and it seems actually the main reason was absence of the people. The levels of population mobility there are extremely high, and so they found that out of every household, on average, 2 members had been travelling to the forest in the previous 6 months. And I think the average duration of time spent in the forest on the last trip was quite long, 26 nights. A lot of people did use hammocks, but a lot reported fever while in the forest. So it's delving down into this detail that can really help to get a sense of just how feasible some of the strategies are. Then I think one of the things that is particularly interesting in thinking about what's going to happen as countries move towards elimination and how that relates to responding to artemisinin resistance is trying to understand why did artemisinin resistance arise when malaria is now so low. In the past, when we found resistance developing to earlier drugs in that same area, it was always said we were always told it was because the forest there was very dense, there were people traveling to the forest, the local malaria transmission rates were very high, and yet now that doesn't seem to be the case. So trying to understand what's really going on there is quite challenging. Also, what does this mean for other regions that are moving towards elimination? Are we going to find out that artemisinin resistance is revealed as malaria transmission goes down? And how does it affect our timelines for elimination? We may have, it's always important for an elimination program to be time limited and planned in that way, but are we going to have to shift and accelerate those timelines? I think I'm not going to go into too much detail about the malaria surveys, but there have been a whole series of surveys being undertaken within the Greater Mekong sub-region countries over the last few years, well, about 10 years, and a big body of knowledge is developing as to what's actually happening at household level. This was just an example of some of the results that were coming out of the survey last year in Myanmar, looking at access to healthcare. And it was interesting to find that people actually did seek treatment very rapidly for fever, with more than 66% actually going and seeking treatment on the same day. And it also showed that in the bottom right-hand part of this, that a lot of the drugs that people were taking were actually not antimalarials at all. Some were taking artemisinin monotherapies, that's the ART mono, but then only 2.4%, should be 0, but it was quite low. But then a large proportion of people were not taking antimalarials for fever. And then one thing that we found was that about 65% of people would go to seek treatment in the public sector in the areas that were surveyed, and 30-odd% in the private sector. And this helps us to work out how to actually ensure rapid access to treatment. Just some of the work that we're doing on in the region on this is supported by the USAID PMI CDC, where we're working on a 5-year grant with partners to strengthen monitoring and evaluation and surveillance in the region. And we're hoping that this will actually be a good sort of basis for trying out a number of innovative methods for guiding our transition to pre-elimination where there is resistance. So I'd like to just conclude with what I would have voted if I'd been voting in the election that they had this morning on whether elimination of artemisinin resistance is possible. And I think that it's still feasible in the region to eliminate malaria in general, but only if time is not lost in moving forward. We don't have that long to do it with the tools we know, and if we don't do it soon, we'll have to slow down, find new tools, and then we'll lose the momentum. Steady investment is essential. A lot of time has been lost at one or 2 points in the fight against artemisinin resistance because funding has taken time to come forward. It could have been worse, I have to say, but certainly at the very beginning when it was realized something needed to be done, it took 1.5 to 2 years before things were actually moving. It can only be done if the information that's used as the basis is accurate and timely and, most importantly, shared. The strategies have to be tested and they have to be sound. The level of commitment needed for this is much higher than we're used to expecting from people. It really does need both a driven workforce, some level of incentives for everyone who's got a role in malaria control and elimination to play that role, as well as getting commitments in the people living in the villages who are seeking treatment and prevention. And really there does need to be a fast-track elimination in areas with artemisinin resistance. Thanks very much.